So if you guys think about it, you've probably watched some old war movie before. They always put some sentry up on the top to look and monitor and try to see if there's somebody about to penetrate the defenses. The minute that they see somebody trying to get over the wall or bridge the defenses, they send an alert. They mount the defenses, they bring all of their full attack against them. So it's kind of like your helper cells serve as a sentry. Their job is to just see if something is coming at them and make sure the right cells get activated. Now, let's go ahead. Let's go back to the very first time we've seen something. Let's pretend you guys are brand new little infants on this planet, okay? You're off of mommy's milk, you're eating solid foods, and you've got your own immune system going now, okay? You're 4 to 6 months old of age. And you fall down and have a boom cell like all babies might do, or you scrape yourself in some way. Oh God, you're a pretty active baby. Let's make you a little older. We'll make you 10 months old, so you're first starting to walk. We'll cut your leg open, okay? You're 10 months old, you're doing the toddle thing, you boom cell, you fall, you encounter a bacterium. The first time you see that bacterium, and you cut your leg open, so you've broken through the physical barrier. You have phagocytes. Those phagocytes are going to eat the bacterium. Nom, 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 nom. They're going to munch it apart into tiny little pieces. And each and every one of those pieces is something your body has never seen before. So they're going to present all of those pieces on their surface. You'll have, how many pieces do we have up here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? All 10 of those little different chunks of that pathogen can get presented in small ways. So the antigen-presenting cells are the dendritic cells, are the macrophages here. They'll present all sections. 1, 2 will be over here, 3, 4, 5, 6, 7, 8. And they'll present them all in MHC molecules. And what is going to happen is that little tiny baby's got T cells. In fact, the first T cell that might encounter it is probably going to be a helper T cell. And they're going to say, wow, look at number 2. Okay, I'm going to create some memory against number 2 here. And now it's going to mount this guy to start working. And it says, well, my job is still to also activate those. So it's going to make this guy start working as well. And when this starts working in really high abundance, it's going to create enough stuff that actually turns this guy on too, so that this guy can turn around and put the kibosh over here. He wants to turn those other 2 off. I'm going to push this board against it. So that when the TH cell mounts a strong enough response, the suppressor is going to come in and say, great, good job, you killed the infection. Now it's time to stop it. It's like a negative feedback control mechanism. If you don't have the suppressor, your immune system would just keep raging and raging and raging, even though the infection was already gone. And so the suppressor is doing nothing more than serving as a regulator, ensuring that you don't have an overreaction to things as well. What would happen if I kept overreacting to a non-existent infection? It takes a lot of cells, guys. This takes a lot of work. It takes a lot of energy. I would be sick and depleted. I would wear down my metabolism. I would use up my energy source. It would affect my growth, which is the exact reason why every time you're fighting an infection, you feel run down, you feel fatigued. Because just to mount your immune response, it takes enough energy that your body feels that sense of fatigue. Well, if you're a brand new baby and you don't have proper suppression, that amount could easily kill you, okay? So you got a little tiny baby. And you and me, though, if we don't have the right amount of suppression, it could be one of the reasons for an autoimmune condition. And that's why individuals who have autoimmune conditions oftentimes have 1 or 2 or more, because they don't have the right sense of checks and balances to their infectious disease. Okay, guys, so memories, remember things, helpers continue to stimulate the immune system, and suppressors sort of slow it all down. Now, helpers along the way, when they start activating memory T and cytotoxic Ts, they also will actually promote the activation of B cells. And so for the first time ever, you actually see that interconnectedness between cell-mediated and antibody-mediated, okay? So you have these conditions, these are your cytotoxics, and then on the other side we have our helpers. B cells, though, let's go to it. Let's imagine that we have activated somehow. We have presented information. T cells have done their job, but what the heck are B cells during that time? What are they doing? Are they just being lazy doing nothing? I sure hope not. I'm gonna get those guys and put them to work too, because we want to mount a response that is so effective that we kill it both ways. We want to not leave a single potential pathogen behind to harm our body. And when you're that brand new little toddler baby, your immune system doesn't have any memory. So now you're at risk of other types of infections. That's why you pay very strong attention to when an infant starts running a fever, or when an infant has situations of inflammation or conditions where they have the little tiny boo-boos that don't seem to go away. Because you need to pay attention, because they don't have all of the memory that an adult has. Even a child, the child that's getting their tonsil inflammation, you're paying attention to that because they're still at a vulnerable age. Okay guys, so B cells, they work in a different way. And the way that they work is by the production of antibodies. And we have a bunch of cool looking antibodies. Now antibodies, as it stands, can sit on the surface of B cells. They can be released into things like your blood. And they can all serve to do something called sensitization, okay? B cells, though, in this scenario, they're showing an inactive B cell. A B cell that's just kind of chilling, waiting to see something that it knows, waiting to encounter an antigen presentation, okay? The B cell itself will first encounter the antigens, and because B cells can also work as antigen-presenting cells, the first thing that can happen is that antigen can bind to portions of their antibodies, the ones that they have floating around on the surface of their cells. Antibodies are specific. Okay, so when we talk about adaptive immunity, what was the other type of immunity we could call that? Specific. All right, so this guy was non-specific, so then these guys were specific. And so antibodies are highly specific, meaning I'm going to have antibody number 1 sensitive to number 1. I'm going to have antibody number 2 sensitive to number 2. Antibody number 3 sensitive to number 3. This one right here, when it encounters number 1, so if you encounter antigen number 1, put antigen number 1 right there, it's not going to recognize it at all. The only thing it's going to be able to recognize is antigen number 3. So antibodies are specific to the antigen that they know about. They are specific, they're made specifically to recognize one antigen, not 10 different types of antigens, one. So they first recognize an antigen. The antigen will then go through a process of actually getting itself represented to the surface. And then they can actually help the T cells as well as be recognized by helper T cells and therefore boost both sides of immunity. Helper T cells, like I mentioned, bind there and they kind of co-stimulate to the other side. And so this is that connection between T cells and B cells, is the fact that many B cells can also serve as antigen presentation. B cells activate T's, T's activate B's, and they work together to activate both sides. Now when B cells start doing their thing, here's what they're actually doing. They're dividing themselves into two categories: memory, and then all of the cells that they have so that they can make more antibodies. Because if antibodies are the specific side of them, they need as many out there as possible. If I have encountered something I have seen before, and I want to test my blood because I have seen that, I ran into it. Let's use chickenpox again. I've seen the chickenpox. Okay, so someone in this room has the chickenpox. I'll come hang out with them. We'll spend a day together. My immune system will boost the total amount of antibodies that I have against the chickenpox itself, the actual virus. You'll see a raise in the total antibody level. And you'll see that those antibodies are specific to the varicella virus. So I'm going to go ahead and start producing, making a ton of antibodies to something I know. If I don't know it though, it's the first time I've infected by it, the first time I've seen it, I have to create the memory first. So we always chunk away a little bit to memory and a whole lot to activation. But we always make sure we save a little bit to help us remember that for next time. That's like one of our first priorities, is to make sure that we catalog, we say, oh good, encountered this one, putting it in the memory book so that if I see it again, I'm even faster at my immunity the second time through. So the two types, memory and plasma. And then plasmas, they grow very huge. Take a look at their endoplasmic reticulum. Take a look at their Golgi apparatus. Do you see why they should draw those lines around them? That's because they are so active in production of proteins. They are just big, fat, antibody-making machinery. They are just factories to produce antibodies. So plasma cells really do have a big shift. Once they undergo their activation, they start producing antibodies in massive quantities. Now, I wish I could just tell you it's as simple as this, but not all antibodies are created equal. Some antibodies are different than others, so we're going to get into that too. Antibodies, as a whole, have a constant structure to them, okay? And I draw them like a little tiny Y for you guys. I have a good video on it. I might show that video, especially if I'm talking a lot. I draw it like a Y. But what it really is it's a couple of different types of proteins, okay? So I draw it like the Y, but let's make the center, this is like this. It's almost like one side of a Y and another side of a Y, okay? And this bigger, larger chain is considered, these are the heavy chains, okay? Because they're big and heavy and large. You see that? At the very tips of these heavy chains, they have portions of them that are variable. So this portion right here at the tip and this portion right here at the tip is the variable portion. So the side of it that's not variable, that's the same for all of them, this portion in black, that will be our constant portion, okay? On the other side of it though, these guys have a heavy and a heavy, and in the middle they lay kind of another piece, and that smaller piece is not as heavy, so we call it the light chain. And the inside portion of that light chain is still constant. Okay? But there is an outer portion to it, and that's the stuff that's going to come in contact with my antigen, and that outer portion is variable. Okay? So the structure of this is kind of neat, kind of interesting. Not all are created equal. In fact, you have 5 different classes of antibodies inside you. And each one of those classes serves a different role or a different function. The constant portion is the same. It's the same. It's the variable portion that will change in response to different antigens. So this portion right here and this portion right here that comes in contact with the antigen, it's going to pop itself off, kind of play like mix and match, like Legos together. They're going to build different colors onto their pieces dependent upon the type of antigen they encounter. Have you guys ever saw the Lego movie? They're like master builders. They're like able to construct and then reconstruct dependent upon the type of antigen they encounter. So the constant stuff just holds it together. But the variable portion is what is variable dependent upon the antigen you encounter. So being variable is kind of a good thing. Now you can have the ability to recognize a ton of different foreign particles. Being variable is a very positive thing because now you have the ability to identify a whole bunch of stuff you encountered in your lifetime. All right, guys, so we'll go ahead and watch this one. I think it'll help. You know what, before I even show this to you, let me really go quick to just show you guys, I do have some videos under this chapter that might help. Oh, that's 23, it's 22 then we'll show you. I have some videos under 22 that might help. Some of them just show like kind of graphical representations of some of this that could just be the simple way to revisit it. And they might just be that little tiny thing that sets you over to understanding it. This one and this one, these are more like news reports. They're kind of neat, but they're not as much as actually the science of these other ones. So that might help you a little bit. This one's really neat on cytokines. So I just want you to know what resources you have. All right, guys.
Let's suppose that you're writing a really important email to a colleague.
There are 5 different isotypes or classes of antibodies. Each isotype differs in its constant region of the heavy chain. This is not to be confused with variation of the variable regions of antibodies. Those are the regions antibodies use to bind to specific antigens. As a class, we are going to take a little field trip to a beautiful and scenic field to learn about these 5 isotypes. As we arrive in our school bus to our beautiful field, the first thing we see is a field full of green grass. This green grass is representative of immunoglobulin G, or IgG for short. IgG is the most common antibody found in serum, and the only one that crosses the placenta. This means that the only antibody class, or isotype, found in fetal circulation is IgG. In addition, IgG makes up about 80% of all of the antibodies found in serum. Like grass, it's pretty darn common. In addition, IgG is the stereotypically Y-shaped looking antibody. It has 2 arms, which bind to an antigen, and 1 tail, the Fc region, which can be used for identification by our white blood cells. As we continue to scan the beautiful field, we notice that there are giant maple trees standing here and there. These big maple trees represent immunoglobulin M, or IgM for short. This is the largest class of antibody and the first to be produced during an immune response. IgM is truly gigantic. You can basically think of this antibody as 5 IgG molecules stuck together in a circle. That means there are a total of not 2, but 10 binding sites. Besides maple trees, another type of tree we see scattering the field is the elm tree. Allergy sufferers know this tree all too well. The elm tree releases lots of pollen that wreaks havoc upon many people. Those allergic reactions have a lot to do with immunoglobulin E, or IgE for short. IgE is the isotype of antibody that is rarest in the serum and is mostly found bound to mast cells and basophils via its Fc region. The mast cells and basophils are white blood cells involved in many things, notably allergic reactions and inflammation. When an allergen binds to the IgE found on the surface of these cells, it signals the cell to release all sorts of molecules that cause the typical inflammatory responses, such as congestion, itching, redness, and so on. Since the elm trees are causing so much trouble, let's quickly move away from them. As we do so, we come up against an arroyo. These are dry creek beds that fill with water after heavy secretions from the sky. That is to say, after a lot of rain. Our arroyo is a metaphor for immunoglobulin A, or IgA for short. This is the isotype of antibody most commonly found in bodily secretions. For example, it can be found in mucus, saliva, tears, and milk. It's more important than being just the most commonly found antibody in bodily secretions. There's a reason for all of this. For example, your upper respiratory tract has mucous membranes to which viruses and bacteria love to attach. Well, it's the job of IgA to bind to these viruses and bacteria and prevent their attachment and entry into the cells of your mucous membranes and beyond. Last, but certainly not least, as we cross over the arroyo, we see that on the other side are some deer. We see that the deer are quite young and still maturing. Our immunoglobulin D, or IgD, is the class of antibody found on B cells that is involved in their maturation and activation. Basically, IgD helps our little deer grow up a little bit more by exposing them to the world around them. One last thing you must know before we leave the field is that IgD, IgE, and IgG are all called monomers and have the characteristic shape of a Y with two binding sites. This is in contrast to IgA, which is a dimer or combination of two monomers, which gives it four binding sites. And as previously mentioned, it is also in very stark contrast to IgM, which is a pentamer or a combination of 5 monomers, which gives it 10 binding sites. That's why our maple trees are so big. Now that we've left the field and are on our bus ride back to school, let's review everything we saw today.
All right, I'm gonna pause it, 'cause that way we
Immunoglobulin
can
G is the most common
do it
antibody
ourselves and go
found in
back one more
serum,
time on our
and
own
the
to
only
this
one.
Okay guys, so there's a lot of strategies in place. Match is the one your textbook says to keep them straight. Yeah, I like Match. Gmade is what I think I used to use. So whatever you need to help you remember the types of antibodies, let's go back and look at their structure just briefly. At the sites of your antibodies, you do have some very specific shapes. So you have one long heavy chain, and that long heavy chain is paired with another long heavy chain, and they're all held together by little tiny sulfur bonds, disulfide bonds. On the tips of them, though, is where you have variability, and so these ones that they put little stripes on, these guys are the variable segments. And you'll kind of like play your Tinker Toys. You'll do your Lego master building, and you'll reconfigure these in response to different types of antigens. So you keep this other stuff constant, helps it hold together, and you just reconfigure the variable portions. And they will all bind to antigens on their uppermost kind of tips of them, like where I show that one trying to bind to a 3. So they're going to bind specific antigens at this location, here at the tips of their variable portions. And so there's a lot of ways that we've been able to see it, but if you look at like an example like this, one that's binding to the surface of an actual sub, the stuff on that antigen that they bind to is called an epitope. And so you have a big protein, like the one you saw out there. It's cut into tiny little pieces and chewed up into small little portions of antigens. Takes a large pathogen into something small, and then it's that small portion that your antibodies can specifically identify. And some antigens are what we call complete antigens, in that both portions of the antigen can bind to both sections of your variable region. Sometimes though you'll have just a partial antigen called a hapten, and then you'll fill in the other site with a carrier molecule. Haptens elicit a slower, less efficient immune response than do complete antigens. And it makes sense. If I can only bind about half of the sites, if I'm not as efficient at binding them, I'm not as efficient at activating them. So hapten responses are not full responses. In fact, that's the basis for a lot of our allergic responses are hapten responses. Okay guys, so these antigens bind to the variable portion at the antigen site. And we have 5 classes. Let's go through them. IgG is hands down the biggest class. 80% of all of your antibodies is IgG. So when in doubt, remember that IgG is the most abundant. We'll find it if I actually search your blood and run a serum analysis of what's going on inside your blood. I'm going to find IgG in the highest amounts. Okay. IgGs work really strongly against most types of infectious particles, including viruses, bacteria, even portions of bacteria, toxins. These are the only ones that really can cross across the maternal membrane of the placenta. And so they are the ones that give us that passively acquired immunity. They're the same ones responsible for that Rh response. So when an individual has an Rh response against their offspring, that hemolytic disease of the newborn, that's caused by IgG antibodies attacking the newborn. So you've actually encountered the term antibodies multiple times in this class, but think it back just a little bit. IgE is really famous for its role in the allergic response. It activates a lot of things, and it can bind to surfaces of basophils and mast cells. And this guy really kind of sends a re-stimulation to inflammation. So I think allergy when I think IgE. IgD, this guy is kind of boring, it's kind of lame. It helps other things work a little more. It doesn't do as much on its own independently. IgD is like kind of like one of those more forgotten ones, just because its role is more to support others than to do anything active itself. IgM though is important in a new way, guys. So IgM is not the most abundant. IgG is the most abundant. However, IgM is the first one you're gonna get when you encounter an antigen. So when you encounter an antigen, IgM is kind of the first one to spike or to peak. Then over time, you start to produce IgGs instead of IgM. So IgM, the levels go high quickly, and they go down quickly and are replaced by IgGs. So these guys do a really good job against like bacteria. They can also be very important in when you're actually seeing a patient, or you might accidentally hook that patient up to the wrong type of blood, because these guys are going to serve a very important role on that initial early response causing agglutination when you have incompatibility of blood types. So we've got IgG, most common, IgE, think allergies, IgD, kind of supportive, IgM, first line of defense, okay? And then IgA, this guy you have naturally in places like your saliva and your mucus, even in semen, tears. These guys really work to prevent things from getting past and into the physical barrier. IgA antibodies will work, and they actually usually circulate around by themselves or in pairs. They actually can help to confer pathogen. They can confirm antigen capacity against different types of pathogens, and they work really well to circulate around those mucosal layers of you. If you look at them, there's a different table. Table 22-1 will help you keep them straight. But if you look at them, like sometimes they'll show these guys bound together in dimers. IgM likes to cluster, actually in a pentameric shape. IgGs, IgEs, and IgDs will go circulating all around by themselves. Now, if you imagine what these antibodies can do, just shooting an antibody into a solution seems great, but what does it actually do when it gets there? It's this whole division of immunity dependent upon antibodies, but what do they actually do for us? Well, they can do a few different important things, and we're just going to preview them. The idea is that you can understand some of these elements, but I'll go through and actually highlight what you need to know, okay? So the first one, they can do something we call neutralization. Oh, this is actually going to discuss primary versus secondary response. So let me just do primary versus secondary, and then I'll go back to neutralization, okay? The first thing that you got to imagine, though, if it is the first time you see something, you have a primary response. The next time you encounter it, it won't be your primary, it'll be your secondary response. So you have a different type of response the first time you see something to the second time. The different levels of antibodies will vary depending upon if you're having a primary or a secondary response. So the first time you see it, that initial primary response, the next time you see it, you get a secondary response. That secondary response, because you've already encountered it once, you've got some memory set up, it's stronger, it's quicker, it's more prolonged, it hangs around long enough to make sure you rid yourself of that infection completely. So it's because those memory cells are in place. The way that we would measure it on a patient, if we had a patient coming in presenting with an infectious disease of unknown origins, you'll have a physician, again, maybe it's of unknown origins. They're not even sure if it's a bacterial infection or a viral infection. Some of the first things that they're going to do is they're going to run a serum analysis. They're going to look for their antibody titer levels. You're going to get a CBC off that patient and look at what's going on. Check out their neutrophil levels, see them elevated. But you might want to go look further into this infection to find out exactly what type of antibodies are being activated. So you'll measure titers of antibodies. The titer will rise slowly the first time you've seen something. You can actually not see a peak response until maybe up to 2 weeks after the initial infection. meaning that you don't really get that immune response very strong right off the bat. You'll see IgM go faster than IgG, but then we know that IgM is not as strong as IgG. It doesn't do it as effectively, so we really, really need this IgG in place to help us have the best possible immune response. Now the second time, so this is what it looks like, guys. Just imagine if you ran an antibody level on somebody. IgM comes first, IgG comes on, it comes on stronger, and it hangs out a lot longer. This is just the first time you encounter something. What do you think is going to happen the next time you encounter something? The same thing you saw before.
Quick response.
So we're going to hope that our time is faster, that it doesn't take us past a week for us to see our response, that we don't peak out here at 2 weeks. We're going to expect it to come quicker, and we're going to expect the kind of a skewing. IgM is still going to be first, but IgG is going to be stronger and more severe. And look at the difference, guys. You peak out maybe even later, but you have such an extended exposure that you surpassed your initial level with your first response within your first week anyways. And every subsequent response is faster and faster and faster. Because you keep encountering that same thing, your body keeps getting smarter and smarter and more protective. So IgG rises quickly and stays extended longer. IgM is still very quick, rises even faster, but it doesn't go and help as effectively. And then don't worry, just because you have antibody levels going up, you still have T cells going on at the same time, you still have all those innate factors going on at the same time. And it helps if you have encountered it before because you can mount everything quicker. All sides go more effectively the second time you've seen something. Okay guys, so this is what it would look like if we were to map the individual cells across an infection, okay? So we know that if we run a CBC on a patient comes in feeling under the weather, comes to the doctor. Maybe you're seeing this patient not because that person doesn't have a normal cold. Maybe you're seeing this patient because that person is under chemotherapy and is already immunocompromised. So they call the doctor, they're like, I've had a sniffle and a cough and I'm running a fever. The doctor says, come in. I don't care that it seems abnormal. We want to make sure you don't get so sick because you're under treatment for something else. So we're going to run a CBC on that patient within the first day or two of their infection, and what we're always going to see is neutrophil levels go up first and fast. The neutrophil levels and NK levels, they both rise quickly, and you can tell their important role in acting as microphages, or their important role in immune surveillance means that they should be some of the first ones to mount their response. Okay, so we've got them. We've also got macrophages coming along here, and these macrophages are working on presenting the antigens. Cytotoxic T cells are recognizing those antigens, and those cytotoxic T cells combined with their helper T cells are now activating in those plasma cells, and the antibody levels are coming up in direct correlation to the plasma cell production. Does it make a little bit of sense when you see it like this?
This is when you're first
This
exposed
is
to
time
it,
after
this
infectious
follows that.
disease. We've mapped it out. Look at the antibody level. It's still probably low. This is a primary response. Okay? So we have all of them. We've got innate immunity and we've got adaptive immunity coming at it full force. That's what your immune system does for you. It doesn't just single-handedly try to approach something. Because the advantages that, and many of you who've taken the micro or are actively in micro right now, think of the advantages the bacteria has. The bacteria just needs a little bit of food, the right temperatures, the right conditions, and next thing you know, it can grow pretty uncontrolled inside a human body. So your immune system does a very effective job at trying to mount an immune response and to keep it so strong that nothing can keep attacking. So it goes through in your textbook right here. This is, as you know, figure 22-27, yep. And it breaks it down. What would happen, kind of that approach. I don't think you need to sit and memorize what comes next, what comes next, what comes next. I think you need to understand T cell immunity, B cell immunity, and innate immunity. I am not asking you to memorize this table. I am not asking you to memorize 22-26 either. I'm asking you to understand them, not to memorize them. So that's important that you know. Do not memorize 22-26. Do not memorize 22-27. Okay, guys. I think I'm gonna actually skip describing for you all the ways that the antibodies work. I was gonna do it, but I borderline on whether or not it's even relevant. You know what, I am going to skip it. Now, within your section on actions of antibodies, and it talks through each of those actions of the antibodies, how they work, I am not, for the sake of this class, going to ask you to tell me how antibodies work. I just need you to know the classes of antibodies, but you do not have to tell me their individual roles. In microbiology, you will. In anatomy and physiology, you don't need to. Yes, ma'am.
So you just want us to know the 5 types?
Yeah, the 5 types. You need to know the structure of the antibody. You need to know generally what those 5 types work, how they work. But you don't need to know this. This list that you had right here, you don't need to know how each and every one of these occur.
Okay.
I'm going to tell you right now, in micro, you will. But in anatomy, not necessary. So, how do you build an immune system? Well, if you are immune to other things, that means you're competent to those things. Now, if I allow something to come against me, I'm tolerant. These were some terms we've already learned. But competence against something means I can recognize it and I understand it. If you're competent about the materials in your textbook, you understand them. So your immune system can usually determine itself competent. Commonly, it takes about 3 or 4 months after the initial infection to be what we term competent. The more we encounter something, the faster we are competent against it. But how do we develop competency from infancy on up? Well, your fetal thymus itself starts producing T cells. Your liver and your bone marrow make B cells. And a 4-month-old fetus can actually make its own antibodies. If you encounter certain types of infectious disease while in utero, you may actually develop competency against certain types. Several of them are toxic to a fetus, but several of them the fetus can survive through, and it'll actually make it through and develop some kind of an immunity. Before you are born, the mother's IgGs are really doing a good job. They'll pass through the placenta and protect the fetus. They're giving passive immunity to that fetus. It's natural passive immunity to that fetus. But after an individual is born, now it's on its own. There's no more placenta, there's no more maternal antibodies unless they receive the mother's milk. In the mother's milk, they'll get IgA. IgA antibodies are the ones that go into the mother's milk. And so this immunity lasts for a period of time, but they've done several studies to measure it, it's only strongest within the first couple of months. Over time, the mother's milk will stop generating high levels of these antibodies. So over time, the weaning process, the natural weaning process, it's a necessary thing. It's not any benefit over an extended period of time beyond that first year. Really, the mother's milk stops producing these in very high quantities at all. Even the first couple months, though, it's really, really high. Colostrum is almost entirely antibodies. But then it begins to attrition pretty quickly to how much she confers. And to be honest, once an infant is growing and growing larger and encountering their own pathogens, the mother's milk is not as protective as it could be anyways. We know IgA is not a strong response. We need that IgG response. We need it fast and effective. So even the mother's milk coming in through the gastrointestinal pathway, it isn't very effective over time. So the baby needs to start building their own immunity. And the infant will. They'll start making IgGs, they'll start raising their levels. At about age 12, an individual will reach kind of where they're going to start producing. Their thymus will begin its attrition pretty significantly over there at around age 12, around puberty. Inside you, though, you use so many different things and factors. The latter portion of your chapter talks to you about cytokines. You even have a figure in your textbook that talks about the different interferons, the different types of tumor necrosis factors, and the different types of cytokines, okay? So these guys are all going to be lumped together. And I want you guys to look, it's called Spotlight. It's figure 22-28. It lists them. It is of my opinion that these are relevant, they are important, they are things that are very helpful and beneficial to your understanding, but at this time, I think they are not necessary for anatomy and physiology for you to sit and memorize each and every one of their individual roles. You need to read it, you need to try to understand it, you need to bring questions about it, but this is not going to fall under the required portion of our class, okay? So figure 22-28 will not be required. Okay, guys. Now, if we were to have all of our levels of our signaling hormones, things that stimulate red blood cell production, things that stimulate white blood cell production in the perfect levels, we would never experience different types of health conditions. But there is one type, and it's a general category with several subtypes of it, of disorders called autoimmune diseases. We've talked a lot about them historically in my classes, but one of the reasons why I talk about them a lot is because for the first time ever, your body doesn't understand the rules of tolerance. And it becomes intolerant to itself. And so autoantibodies are antibodies that are produced against your own healthy cells. And it sometimes is because you get the wrong cues. Sometimes when you're a brand new baby, you teach yourself the wrong things. Over time, though, you've got a breakdown or a shutdown to tolerance. Lots of examples: rheumatoid arthritis, diabetes type 1 could be examples under autoimmune disease. I'm sure you guys have a list. I know a few more get mentioned, and on your disease list there's a generalization to the category. So I encourage you to look at it a little further. We've actually talked about a lot of autoimmune diseases in different body systems, and we'll continue. There's a few more that we'll keep bringing up in other body systems. Talk a lot about diabetes when we get to the kidneys. Okay. Now, there are other diseases that can happen for a variety of reasons. There are some people that are actually born on this planet without a sufficient immune system. They can have one division, their T cells insufficient, or they can have their B cells insufficient. Or, as it turns out, they can have a condition like this one where they don't actually have proper information related to how they produce these. They might have a very small or minimal response. So they have a combined immunodeficiency where both their T and their B cells are not sufficient for survival. And that's something called severe combined immunodeficiency, or SCID. And you might know this person. Have you ever seen a movie about this? The person that has no immune system. The bubble boy, right? It's not abnormal. It's not some fake made-for-TV type of thing. There's actually individuals on our planet that have no competency against any infectious disease. Other things can cause that same depression to your immune system, though. HIV is an example. It's the human immunodeficiency virus. And that virus knocks out your helper T cells. It knocks down all your helper T cells. I've got this little tiny arrow right here, guys. Look at your helper T cell. Your helper T cell, and I should draw one over here to the B cells too, right? So your helper T cell works with suppression of the immune system, works with activation of the cytotoxic, works with activation of the plasma B cells. Now I'm going to just present to you a world where you knock down this. Now that this isn't here, this doesn't get activated, this doesn't get made. There's no need for suppression because those aren't working. There's no parallel connection over here to this. And next thing you know, individuals who have a virus that knocks down those helpers have pretty much knocked down their competency in all areas of their adaptive immune response. So HIV can sometimes lead to acquired immune deficiency syndrome, which is acquired by the virus, but it's an individual that now no longer has the competency to combat other types of infectious disease. We know that lots of drugs that you may give your patients, especially if we go back to people on chemotherapy, a lot of chemotherapy drugs will suppress an individual's immune system. I have to imagine this: cancer, a disease where your cells are just growing and growing and growing. Well, what's one way to kill the cells that are growing and growing and growing and growing? You're going to target those cells that are the most active in a body system. What are some active cells in your system? What cells do you turn over at the fastest rates? Your skin, your hair, what else? Your erythrocytes, right? Erythrocytes are 120 days. Neutrophils got them up there. Erythrocytes are 90 days. Neutrophils are 120 days. Most of my white blood cells don't have the life that other cells have. So if I am trying to treat somebody of a disease because their cells grow too quickly, most of the drugs will also knock down the immune system. That's why you see your cancer patients, depending upon the therapy they're on, losing their hair and slopping off their skin. It's an unfortunate side effect of the drug that might just be saving them from the cancer growing, but then it means that that person, one little sneeze can put that person in the hospital. Okay? We know radiation can do the same kind of thing too. Now, if your immune system is knocked down, that really stinks. But you know what also stinks? This guy right here. When your immune system is irritated and it's mad and it's not paying attention to the rules. And what allergies are not our immune system getting depressed. On the opposite side, it's our immune system getting too angry. Too angry about something that it shouldn't. So it's called hypersensitive. It's now too sensitive to an antigen that it shouldn't interpret as that. For those of you that have allergies, if you have allergies to pollens or things in your environment, there's small little tiny antigens on the pollen protein. It's a tiny little antigen that your body becomes so sensitive to that it makes your eyes water and it establishes a histamine response. It lets some complement go. And next thing you know, you're a big sloughing, sneezing mess, right, when allergy season hits. We have 4 major types of allergic response. 4 major types of allergic response. And we'll actually kind of show you what happens. The first time you encounter the allergen, maybe that's a pollen, like I was talking to you about. That allergen is just is presented to your cells like a tiny little allergen particle, so it goes through antigen presentation. And you become sensitized to it. And the first time that you see it, you create some memory of it. Okay? Now, I wish you wouldn't. I wish you weren't sensitive to pollen because it's not going to hurt you. It's not an infectious disease. Your body doesn't need to be sensitive to it, but some people just are. Okay, cool. So the first time, this is what happens. Nothing big, nothing too significant. What about when I see that guy again? What's going to happen the next time? Alrighty, next time I see it, and every subsequent exposure, I'm going to activate cells like mast cells and basophil cells. And I'm going to remember right from this second onward how important mast cells and basophil cells are to the allergic response, aren't I?
Yep. Better write that down.
But how about
Mast cells, basophil cells are important to the allergic response. That should be what you wrote right there. What's up?
instead of like pollen, how about consider yourself?
Yeah, same thing. So no matter what the particle is here, the first time I see it, I'm going to mount an immune response. The second time, though, I've got a whole bunch of IgEs hanging out now. They're working with my mast cells and my basophils, and these are filled with these little granules. And then when you run into the allergen, those little cells are going to release all their granules filled with histamines, filled with leukotrienes, filled with other types of molecules. And when they do so, now bring it on. That's why typically if you move to an area and you encounter the local pollens and local things in the atmosphere, your first year, second year, third year, usually you get a little bit of sniffle, maybe a little bit of allergy, but about your 5th year living there, you will usually have your worst allergy season ever. And if you had a history of allergies where you lived previously, get ready for it. Your 5th year or so is when these guys are at a peak level so that you're going to subsequently have bad allergies every year beyond that. And if you live in an area that you don't have any allergies and you move somewhere that you do, it's probably because you've just encountered something that your body is super hypersensitive to.
And what would an EpiPen do to these cells?
Okay, so as it turns out, we have different types of reactions, right? Remember, you got different types. You had a question, though. Let me ask yours, and then I'm going to answer the Epi one. What's up?
I moved to Sierra Vista, but when I moved back, I've lived in Tucson my entire life, but ever since I've been back.
You're resensitized to something. You may have had it when you were younger, but now your body has just decided to go crazy. Also, hormones play a big role in allergies. You guys know genetics. Most people, if their mom has allergies and their dad has allergies, they've got allergies. Doesn't matter that you grew up in that environment, it just matters what type of the season. So when the trees are shedding their pollens is usually when it's at their worst, and yes, we're entering that time of year, guys, get ready for it. All right, there are 4 types, classic categories. The first one is an immediate one. This guy right here is the environmental allergy one. This is causing allergic rhinitis. It's the sneezing and the sniffling when you ran into that pollen. This is when you become itchy or something to something that you've seen before, and it gets you really, really fast. Usually very rapid, can be very severe. Type 1 allergic responses, usually like I mentioned, very specific. However, depending on the type of allergen, can be severe enough, causing conditions like anaphylaxis. So the antigen depends on how it gets into you. If it's gonna be like something like pollen that I breathe into my nose, it's gonna cause an inflammation all the way down my respiratory tract, giving me that rhinitis. But what if it's like, I don't know, peanuts, and I take a nice little bite or I inhale it and somehow it enters my bloodstream, and I'm severely allergic to peanuts, it might lead to the condition called anaphylaxis. Anaphylaxis causes cells throughout the body to be sensitized, causes capillaries to become permeable, usually preceded by like massive swelling into the tissues, hives. Causes contractility of the smooth muscles, specifically in your respiratory tract, making or occluding the pathway, so it makes it difficult to breathe, and can cause such a severe amount of responsiveness across the body, leading you into a circulatory collapse called anaphylactic shock. Okay, guys, so what do? We take drugs. We take things like antihistamines to help us fight allergic responses. Histamines are the root cause of that inflammation, so we take something that blocks them from working. And that's like our Benadryl. Now, a lot of criticism out there, because Benadryl used to be like considered a very safe drug long term. Now they're linking it to stroke risk. They're linking it to a few other neurological things. Up to you. There's an article I found right here. It's a little older, but which allergy medication is the safest? Many people that deal with allergies already know what they're doing. They're taking Allegra right now to get ready for the rest of the year. They're putting Zicam up their nose or whatever they need to do. There's so many out there. Definitely time to explore. I would use Benadryl more as a short-term fix. Okay, guys, that's just one type of hypersensitivity. There are others. There are other types of hypersensitivity that aren't as immediate, and those other ones are ones we'll talk about really detailed in micro more than here. But they'll include the ones that are involved in blood typing or organ failure. They'll include the important ones that related to those things, and we'll talk more about them and categorize them in micro where that's more relevant. Now, if your immune response was just perfect your whole life, that'd be lovely. But guess what happens? You come to school, you study for a quiz or an exam, you're stressed out, your immune system gets depressed as a consequence of stress hormones. In fact, what we know is glucocorticoids can actually limit your immune response. So let's play it back. Let's rewind our brains back to ANP1 all the way back to when you learned about the autonomic nervous system. What did you learn about the autonomic nervous system? 2 divisions. Sympathetic, parasympathetic. I'm ready for the fight for my life right now, okay? I'm under sympathetic. I'm in a case of stress. During the time when I am stressed out, do I give a crud about my immune system? No, I'm fighting for my darn life. So glucocorticoid's job is to suppress all the systems that my body does not need in an attempt to help me get me through this fight for my life. So under periods of stress, these hormones protect you, but they suppress your immune system. Now, their suppression over the long term in cases of chronic stress. I've got this quiz this week, I've got this exam that week, I gotta pay these bills, I gotta go to work. And you're living this life of high stress. Unfortunately, you are usually perpetually depressing your immune system, now making you vulnerable to the next infectious disease you encounter. So, glucocorticoids, great thing to save your life, get you up in the morning, and all those important things, very terrible for long-term impact on immunity. Your immune system will definitely go down with age. You produce less and less hormones, you produce less cytokines, you produce less colony-stimulating factors, all those things that I mentioned to you on that list there. You don't respond as well, your memory cells start to die off. So as a consequence, when you get older, you get sicker over smaller things. That's why they indicate that individuals of a certain age be the ones that are the recipients of the flu vaccine. They don't indicate it for the middle population as much unless they're healthcare workers or required by their workplace. They recommend it for the very young and the very old.
Is that the reason they get more UTIs than anything?
Oh, for sure. We'll talk about that in kidneys too. You asked me about an EpiPen, by the way. What your epinephrine is going to do is not through a histamine response, but epinephrine is going to cause that vasoconstriction. That epinephrine is going to work in the opposition, right? So it's a sympathetic hormone, so it's going to basically protect and close off the airways in a very fast, close off the capillaries in a very fast way to prevent the airways from full closure. All right, guys, so your immune system, it's a pretty big guy. It's a pretty important one. I know that this was not the easiest. I know that it's kind of hard to go through it. Let's make sure that if you have questions now, ask them before we move on to another system, that kind of thing. We'll take a little 5-minute and then we'll start on respiratory. But let's make sure that if you do run into questions, you ask them. It's important that you understand it. I have cut out chunks of this chapter from your need to know.